Good afternoon to each and everyone, and thank you for inviting me here, especially Dr. Sandeep Jasuja. I am Dr. Bhavesh from Tangam Cancer Center, Namakkal. I'll be talking about concurrent chemotherapy in this non-small cell lung cancer. I think most of the things have already been discussed by Dr. Anil, but I'll see what I can add to it. We know that the burden of lung cancer in India is tremendous, and we lose almost 90% patients just because these patients come in advanced stages, almost stage 3 and 4, and we cannot give them a curative intent for most of the time. So what is the when to use concurrent chemotherapy is important. Most of the thing is already covered. What are the benefits over RT alone? What are the regimens which are available? I'll not go into the individual data, which is difficult to complete in 10 minutes. And comparing the efficacy and safety of the chemotherapy regimen. So coming first, what are the indications? So very straightforward indications are stage 3B, T4N2, stage 3C, T4N3. And if we find ipsilateral mediastinal node which is positive, patient can go for definitive CTRT. If there is a contralateral N3 node, mediastinal node which is positive, again that becomes an indication for CTRT. Stage 3B, we are having N3 node which is positive, and these patients again are the candidates for definitive CTRT. This is again one group where N2 nodes are positive, T1 to T3, and this can again be given an option of either definitive CTRT or induction chemo followed by RT. And this usually happens very less nowadays because the patients are evaluated very well by the surgeons, and post-op finding a patients with N2 and margin positive is very rare now. But this again becomes an indication for definitive CTRT or an adjuvant CTRT actually. So these were all NCCN guidelines. Coming to the ESMO guideline, again, it concurs with most of it. Extensive mediastinal N2 nodes, N3 nodes, unresectable N2. This all becomes the indication for non-surgical multimodality treatment. And of course, nowadays, most of the cases are being discussed in a multidisciplinary team. And if the team feels that patient is not a candidate for surgery, this patient should get a non-surgical or a definitive CTRT. So until 1990s, RT was alone as a treatment of choice for all inoperable NSCLC, and having very poor 5-year survival in single digit, less than 10%. What has chemotherapy done extra? So chemotherapy actually has a dual effect. It not only increases the radio sensitivity and increases the local control, but it also decreases the chances of distant metastasis. So hence it has become the standard of care now. Rather than going into the individual data, this is a meta-analysis of 14 trials comprising almost 2,000 patients, and they have concluded that cisplatin-based chemotherapy is the one to go, and there was a mortality advantage, reduction in the mortality at 24% at 1 year and 30% at 2 years, and non-cisplatin-based therapy actually was detrimental. One more analysis, meta-analysis from in the same year, again seeing 22 trials, and these trials again showed that there was an absolute benefit of 4% at 2 years and 2% at 5 years by giving CTRT. This is one of the recent meta-analysis, 2006, again analyzing 9 trials, close to 1,800 patients, followed up for more than 7 years. And we can see there was again an absolute benefit of 4% at the end of 2 years. So this concurs with the meta-analysis which was done almost 10 years back. And concomitant platinum-based radiochemotherapy actually improves the survival. It has been re-established. So we do have multiple regimen. Each and every regimen has its own advantage and disadvantage. We have different preferred therapies, especially for non-squamous and squamous. So for non-squamous, we usually go for carboplatin pemetrexed every 21 days for 4 cycles, which is concurrent with the RT. We can give cisplatin pemetrexed again in the same way, followed by an additional 4 cycles of pemetrexed 3 weekly. Paclicarbo can be given weekly with concurrence with the RT, and additional 2 cycles of paclicarbo 3 weekly. Very difficult regimen, but usually that's the best regimen which has been seen, that cisplatin can be given at day 1, day 29 and 36, etoposide day 1 to day 5, and day 29 to day 33. So it is 5 days, and there is a 28 days gap in between, and again there is 5 days therapy concurrent with the RT. In the squamous cell, usually paclitaxel weekly is a go-to regimen, or cisplatin and etoposide. So how do we decide? So what is the best regimen? So obviously clinically what we see is the patient related factors, like what's the age of the patient, comorbidities patient has, what is the nutritional status, lung function again is very important when you want to give radiation as well, and performance status of the patient, and whether the patient is platinum eligible or not. So now we have very strict criteria of putting patient either they are platinum eligible or ineligible. And of course, therapy related factors, because we know this therapies comes with toxicity, and the toxicity adds on when you give chemotherapy and radiotherapy together. So this is one of the recent meta-analysis 2019. Again, it showed that these are the various trials which were included. I'll not go into the individual trials, but what did it show? Recently, it is showing that, of course, the etoposide and cisplatin is more effective than the pacli and platinum, and both in OS and PFS, it is comparatively little better. And if the individual, if we go by the individual therapy, so S1 cisplatin was most preferable regimen and having the best efficacy with lower risk of causing adverse events, followed by tegaferuracil cisplatin and pemetrexed cisplatin. So this is something which we have not been using. We did not have S1 till recent past, but now we have S1. Probably we can also start using such regimen and see how the effect are. So as Dr. Anil has already mentioned, there are so many different trials which are already ongoing and using the effect of immunotherapy also with concurrent radiotherapy, and probably this may become the standard of care in near future. Take home message from my side will be, when we are going for a concurrent radiotherapy and chemotherapy, it should be a platinum based chemotherapy, preferably cisplatin. If we know that etoposide plus cisplatin can cause more hematological side effects as well. We know that radiation causes non-hematological side effects in the form of esophagitis, which is a troublesome side effects while we are treating the patient. If we cannot go for eto and cis, maybe the next go-to regimen should be taxane and platinum. In near future, we will have this combination of immunotherapy or TKI with RT, and it may change the outcomes better than what we have right now. For prime time, what we have is to consolidate the achievement what we have got with CTRT by giving durvalumab as a consolidation immunotherapy according to the Pacific trial, and it has increased the survival to almost 42% at the end of 5 years. There is ongoing trial of Pacific 8 where they are looking one step ahead, durvalumab versus durvalumab plus domvanalimab. It is an anti-TIGIT antibody, and they are seeing whether addition of another molecule to durvalumab it pushes the 5-year overall survival beyond 50%. So this is for the future. We don't know what's going to happen next, but as of now, CTRT is a drug, is the treatment of choice, especially for patients who are not a candidate for surgery. So thank you, and that's my team from Tangam Hospital.
So thank you, everyone. I think we come to the end of the topics on the management of early stage lung cancer. The next section is very, very interesting, and it's